So the fourth speaker of this session is Levon Bui. So Levon is a second-year PhD student at the Laboratory of Pharmaceutics and Biopharmaceutics in ULB, Belgium. He also had a master's degree in biomedical science from the same university. His PhD work is about developing innovative dry powders for inhalation by spray drying for asthma and COPD. So let's hear from Levon.
Yes, thank you so much for this kind introduction. I would like to thank the organizing committee and also the scientific committee for such an event and also giving me the opportunity to share with you part of my research project. I feel very honored, grateful, and very excited. So this work is focused on the development of dry powders for inhalation based on budesonide, and we have assessed controlled release properties through a pharmacokinetic evaluation. So budesonide is known as one of the inhaled corticosteroids, ICS, and they are the cornerstone in asthma therapies. Asthma is a major respiratory disease. As we all know, it is characterized by acute inflammation and swelling of the airways and block the airflow for a patient that has difficulties to breathe. Asthma is still today a very impactful disease on the public health. People are still dying from asthma today. And the use of ICS, such as budesonide, is meant as reliever and maintenance treatment to reduce the swelling, reduce the inflammatory events on the airways, and eventually open the airways. However, there are some key issues about the use of budesonide therapy. On the first hand, you have the administration frequency that can range from a once daily at high dose up to 2 inhalation twice daily plus 1 as needed, so 5 per day. And on the other hand, you also have the adverse effects, such as stunted growth and candidose infections. And overall, these two key issues represent a serious burden regarding the therapy compliance for asthma. It is also very interesting to mention that budesonide has a very unique capacity to form a budesonide oleate storage inside the lung cells. And this storage is capable and allowed sustained anti-inflammatory effects on the lung tissue. So our strategy to improve adherence to treatment for asthma is to develop dry powders for inhalation for a once daily administration, but at lower doses of budesonide. And so we are aiming for a controlled release and sustained retention property, and we have developed a pegylated lipid matrix based on hydrogenated castor oil, so HCO, and pegylated tocopherol-succinate, TPGS. And so in theory, we would have the budesonide dissolved inside this lipid matrix. To give you a little bit of context, after inhalation of the conventional budesonide drug, part of it will be undertaken by the mucus escalator and also the phagocytosis by the macrophages. Only a part of it will be dissolved inside the lung cells to have the anti-inflammatory effect, and afterwards be eliminated in the blood. Regarding our macroparticles, due to the pegylated lipid matrix, we would prevent the mucus escalator and macrophages uptake, but also slow the release of the budesonide so that the lung cells can absorb it, and the budesonide will be also afterwards eliminated in the blood. What we can see in the blood is, on the first hand, you will have something that is very fast absorbed and very fast eliminated for the conventional drug, whereas for our macroparticles, the release profile will be more controlled with the higher Tmax, a lower Cmax, so that we can have anti-inflammatory effects and stay beneath the toxicity level. So to produce our macroparticles, we have chosen this spray drying technique because it is very suitable for inhaled therapies, but also for upscale production. And we have dissolved all of our compounds in a 100% isopropanol solvent. Among all of the formulations that we have produced, 2 were selected. The first one is named 20.1 because it has 20% of budesonide. The second one is named 5.1 because it only has 5% of budesonide. And we managed to produce them with a production yield of 50%. We selected these 2 formulations and characterized them first by scanning electronic microscopy and X-ray diffraction, and we can observe that we have amorphous budesonide inside these spherical microparticles that also has smooth morphosis. We made these microparticles with high melting point lipid, but this lipid is also very stable against oxidations, so we can expect long-term stability. Afterwards, we evaluated the aerodynamic properties using the NGI technique through a DPI. And we have compared our formulations, so the 5.1 and 20.1, to the BH100, that is our reference, and it is actually the marketed micronized drug. And we can observe several things. First, you have 80% of delivered dose and 50% of fine particle fraction. So we can assume that we have an adequate aerosolization and adequate dispersion. But also, we have 5 to 10% in the stimulating throat part. So we can assume to some extent that we would have low adverse effect in the throat, such as candidose infections. And also, we have a diameter that is very adequate for ICS therapies, since we are targeting the lungs in their entirety. Afterwards, we assess the dissolution profiles. We run our microparticles through the fast screening vector to collect the inhaled fraction, and we assess the profiles in dissolution vessels. We can observe also several things. You have our reference that shows a very fast release profile in the media. However, for our formulations, we have a deceleration of the drug release in the same media. We calculated the similarity and dissimilarity factors, and we can assume and ensure that these profiles are very different from one another. All of these in vitro data were very satisfying, and we wanted to push our study forward, so we started a pharmacokinetic study. And our first step was to make homogeneous blend with monohydrate lactose so that we could deliver to the rats identical doses of budesonide and investigate more closely and with a great focus on the pegylated lipid matrix impact. So after administration to the rats, we collected their blood at very specific time points over 24 hours. We collected the plasma from the blood, and we ran every samples through a solid phase extraction plate so that we could isolate the budesonide from it. And every samples of budesonide were afterwards quantified and detected through a mass spectrometer. And at this point of the study, we were able to make reproducible budesonide-based blends for the administration, but also validate our analytical methods of detection and quantification. And we were able to quantify the budesonide down to 250 picograms per ml, which is really low. Here are our results. So we have isolated the Tmax, the Cmax, area under the curve, and half-time life. And you have on the left side of the presentation the layouts of each profile individually. And we can observe several things. As predicted, we have a significantly higher Tmax, 9-fold higher than the reference with our formulations, but also a lower Cmax. So to some extent, we can assume that we have a controlled release property, and we can also assume that after inhalation of our formulations, we would be able to reduce the adverse effect compared to the reference. Another thing that was also very interesting is that we were able to detect and quantify the budesonide in the plasma over 4 hours, something that we do not see at the reference. And so we can assume that we have sustained retention property also. And when we are looking more closely to our formulations, you can see that during the first hour, the release profile are very different. For 20.1, you have something that is constant, and for 5.1, you have something that is more biphasal. Overall, as general conclusion, perspective, and take-home messages, we were able to produce microparticles that are very suitable for ICS therapies. They have both controlled release and sustained retention properties due to the pegylated lipid matrix that we have made with HTO and TPGS. And in the plasma, the release profile of these formulations are very distinctive from one another. The next step would be to assess the sustained release of anti-inflammatory effects, so whether they are sustained or not, so the PD in other words. And to meet this end, we are working on a preclinical asthma model. And if we manage to validate our proof of concept, we would be one step further in improving asthma therapy compliance and better control this disease. And I would like to close this presentation by thanking all the people that were involved in this study. So first of all, my promoter, Professor Nathalie Wotos, my co-promoter, Professor Karim Amighi, all the people that helped us validate our analytical methods, and of course you for your attention. I hope you enjoyed my presentation, and I'm happy to take all the questions that you may have.
Thank you, Levon, for a very nice presentation. So do you have questions from the audience? Maybe we'll start with a quick one first. So in your pharmacokinetic study, you look at the drug concentration in plasma. So have you got a chance to look at the drug concentration in the lung tissues? And also, do you have the data about the bioavailability as compared with the IV route?
I didn't catch the end of your question, sorry.
So have you got a chance to look at the concentration of drug in the lung tissues and also the bioavailability as compared with the IV?
So we have analyzed the budesonide in the lungs. However, we couldn't find much of budesonide, unfortunately. But our hypothesis is that the budesonide might be absorbed, and as mentioned previously, we would have something that would be very different regarding the budesonide oleate. However, budesonide oleate quantification is slightly or quite different from the regular budesonide. So this is something that we are thinking about starting as experiments. And the result would indeed give us a lot of insights about our formulations and about its properties regarding the control release.
Okay, thank you.
Can I ask, your excipients, your oils that you're using, do you have any concerns about those being inhaled? And is there any precedent for them being inhaled in marketed formulations?
So around about my excipients to be inhaled. Yeah. So the HCO and TPGS are excipients that were not yet considered as safe for inhalation. However, HCO is still already used for a lot of products, such as skincare product, for example. The TPGS is a vitamin E analog, so it should be safe. However, as I know for now, there is a clinical trial for the safety of the HCO-TPGS combination. So this should give us also a lot of insight about the safety profiles.
Mm-hmm. And right at the beginning, you were saying that, that budesonide gets trapped in cells. It's a mechanism by which it's retained in the lungs. Would your formulation affect that mechanism, do you think?
I don't believe so, because my formulation is, my formulations are meant to slow or prevent, actually, the uptake by macrophages, for example, for the phagocytosis, and also slow the release of the budesonide inside the lung cells. But once the budesonide is absorbed by the lung cells, the mechanisms does not depend of my excipients, for example.
Okay. If there's no other questions, I'll follow up with one more.
Yeah, sure.
How does your formulation avoid clearance by macrophages and mucociliary clearance? What's the mechanism by which it avoids those two?
So for the regular budesonide, since it is lipophilic, usually it will be undertaken by the macrophages, especially because it has a very suitable size, diameter, to be undertaken by the macrophages. My formulations, the TPGS, will be found on the surfaces and attract molecules of water. So it will hide partially my microparticles from the phagocytosis, from macrophages, and also the mucociliary clearance. So this is why we chose the amphiphyal TPGS to be on the surface of my microparticles.
Okay, thank you.
Thank you.
So let's thank Levon once again.